Welcome to AETCM Emergency Medicine channel. So today case is a 76-year-old male from 76-year-old male, known case of cancer prostate, status post bilateral orchidectomy on 16/1/23, status post chemotherapy, 5 cycles were done.
Why orchidectomy is done in prostate cancer?
CA prostate query mets they suspected. In
what is the need of orchidectomy?
Need of orchidectomy
in prostate cancer. You recently finished your NEET exam, no? Orchidectomy is done in prostate cancer too?
Stop releasing DHA and...
Most of the metastatic lesions will resolve after this removal of the testis. Okay. So that responds to your androgen, I think. I'm not sure about that, but it's a common practice. Testes will be removed in prostatic cancer with metastatic lesions.
Metastatic lesions. Status post chemotherapy, 5 cycles.
Will it affect the patient? Testicle removal? Anyway, it will affect the patient?
76.
Nothing. It will not affect the patient at all.
Last chemo was done in June 2024. Now came with complaints of fever since 4 days, decreased appetite since 4 days, decreased food intake from 4 days, loose stools and abdominal discomfort since 2 days. Fever was high grade associated with chills and rigors, no diurnal variation, relieved with medications, and loose stools were small volume, no mucus, no pus discharge, and no blood in the loose stools. Around 5 to 6 episodes per day. Abdominal discomfort was generalized. Generalized abdominal discomfort. No vomiting or outside food intake or no similar complaints in the family. With personal history, bowel movements increased, bladder movements unknown as patient was kept on diaper since last 2 days, and no addiction histories, no drug allergies. On examination, he was drowsy, arousable, ill-sustained, oriented to person only, obeying few commands. Pulse rate was 110 per minute, regular.
What is the GCS? Directly you can tell what is the GCS.
GCS was E3, V4, M6.
7 plus 6.
13. Pulse rate is 110 per minute, regular. BP is 80-60 millimeters of mercury. SpO2 98% in room air. Respiratory rate was 20 per minute. Temperature was 101 degrees.
Comment about the BP in this patient. What is the age of the patient?
76-year-old.
Okay. So comment about the BP of this patient.
BP is on the lower side, sir, 80-60. Like considering his age, might be they'll have usually lower BP only. But
age?
76.
What is the BP in an elderly individual? Normal adult male patient. What is the normal BP you are observing in your patients? Is it low or high?
Like a known case of hypertension, usually it will be on the higher sides.
What is the BP? You are seeing a lot of patients now. Elderly individual, what is the common? Why higher side? It is due to arteriosclerosis, not due to atherosclerosis. It is due to arteriosclerosis. They have slightly higher systolic BP. It is not due to hypertension as such. Yes. It is due to the vascular changes that occurs in the patient. So always you expect a higher BP in elderly individual. If it is 80/60 means it has to be really low. Okay.
Yes, sir. No pallor is present, icterus, no cyanosis, no clubbing, no lymphadenopathy and edema. Dorsalis pedis bilateral palpable. Left eye mucopurulent discharge present with crusting of the eye is present. And systemic examination, parabdomen soft, distended, tenderness present in suprapubic and right iliac fossa present, and bladder is distended 2 centimeters above umbilicus. And respiratory air entry bilaterally decreased, right more than left. Bilateral crepitations are present, right more than left. More in right infraaxillary, right infraclavicular area, and infrascapular area, more in the left. Normal vesicular breath sounds. And CVS S1 S2 heard, no murmurs. CNS, no focal neurological deficit.
What adjuvant you use to confirm the bladder? Confirm adjuvant in emergency room.
Confirm
Bladder. She is telling bladder is palpable. How do you know that bladder is full? So immediately you have to do an ultrasound and see whether bladder is full due to urine itself or something else.
Something else. Yes, sir. And a point of care, ABG revealed AKI with metabolic acidosis.
Creatinine is high.
Creatinine is high, sir.
Metabolic acidosis.
Acidosis. And ECG. Lactate was normal for this patient. ECG sinus tachycardia.
Okay.
And initial lab showed CRP of 301, procal of 21, urea 81, creatinine 3.3, total bilirubin of 0.9, direct is 0.5, with total protein 6, albumin 2.7, and globulin is 3.3, 59 OT, PT.
Globulin is higher than
higher.
albumin.
Yes, sir.
What are the conditions you get age reversal?
And multiple myeloma, one condition. And
you divide that into low albumin and high globulin. Conditions which produces low albumin than normal, conditions which produces high globulin than normal. What are the conditions you get hypoalbuminemia? This globulin is actually normal.
Normal, sir.
Albumin is low.
Low. Albumin low can be because of secondary to sepsis.
Okay, sepsis is one.
Secondary and severe malnutrition.
Malnutrition.
And protein losing syndromes, protein losing enteropathy and nephrotic diseases.
What are the conditions you get high globulin?
High globulin is seen in multiple myelomas.
Okay.
And hyper gamma globulin.
Okay. Then chronic infections. Which is a chronic infection? Very common. Common? TB. TB is one common infection. Then rheumatoid arthritis, SLE. So all those conditions also can have high globulin.
Yes, sir. OTPT, SGOT is 59, PT is 16, ALP is 166, and WBC
is it normal? SGOT, SGPT normal?
SGOT is mildly increased, 59, and alkaline phosphatase is also
mildly
increased. Not an alcoholic.
Okay.
WBC is 31.4 with neutrophils 87 and lymphocytes 3.6.
So 31.4 is high.
High.
What are the two differential diagnoses for this?
One is bacterial infections.
One is infection.
Infections.
Bacterial infection is more predominantly then.
31 can be considered for polycythemia.
Leukemia reaction. Second one is leukemia reaction. Third one is chronic inflammation itself can produce increased count. Okay, irritation of bone marrow. Then steroids. If the patient is already given steroids, that itself can stimulate the bone marrow and counts can be elevated. Okay, common thing is infection.
Okay. And HB is 8.9 with platelets of 233, sir.
HB is normal or abnormal?
Abnormal, low. Anyway.
What are the reasons for low hemoglobin at this age group?
Malnutrition can be identified.
Given symptom, what is a common possibility? And this age, what are the other possibilities? With the given symptom and sign, what is the possibility? First possibility is what? Low hemoglobin. Iron deficiency.
CKD. Not a known case.
It's not a
known case.
Hemolysis. So for the first possibility is hemolysis. Second possibility is renal failure. We don't know what is the previous one. That is also another possibility. And the most important one is
nutritional deficiencies.
Malignancy. Elderly individual anemia, you have to rule out malignancy. Okay. If it is a young male or a female patient, then nutritional can be there. And middle-aged female or after menopause, that like bleeding from the post-menopausal bleeding is common.
Yes, sir.
But here you have to rule out a malignancy.
Yes, sir. And MLIs lipase was also done. MLIs of 25, lipase of 6.6.
Okay.
And urine routine showed numerous pus cells, numerous RBCs with proteinuria of 2+, and bacteria 4+, and yeast is occasional.
Is this proteinuria significant or not significant?
Yes, significant, 2+.
What is the reason for that?
Could be like a known case of CKD that has to be evaluated.
What is a common cause for proteinuria like this?
UTI.
UTI is the first common possibility in this patient, but like you told, renal failure is already there, then that is also can produce proteinuria.
Proteinuria, yes, sir. And PSA is 10.7 and cortisol is 12.
PSA is
10.7,
Okay, what is
mildly
the reason
elevated.
for that?
Known case of already prostatic carcinoma.
There is a reason.
Infection, UTI.
Infection. Whenever there is an infection, you are not supposed to do PSA. That is the first dictum. If at all you have done, then that can be due to the infection of prostate or prostatitis. Okay, or spreading infection from the urinary tract to prostate.
Yes, sir.
So you can repeat it after control of infection. Then you have to find out. Okay. So PSA is not a good investigation in acute phase. Okay.
And cortisol is 12.
Normal or abnormal?
Normal only, sir.
Normal.
Yes, sir.
Why cortisol is done for this patient?
Because of hypotension, and his sugars were also low, 60 at the time of admission.
Okay.
So to rule out adrenal insufficiency. Yeah, but he was started on meropenem and
Will you
metronidazole.
do random cortisol or early morning
8 a.m.
cortisol?
cortisol, sir.
Early morning.
8 a.m.
In this patient, so we can do that.
In this patient, random cortisol is important. 8 a.m. cortisol is done in a patient who is fully stable. We want to rule out adrenal insufficiency long term.
Long term.
But in this patient, you have to ask for a random cortisol and start treatment if you think that adrenal insufficiency. You start your hydrocortisone or dexamethasone. And that is a random cortisol, not 8 a.m. Okay.
Yes, sir. He was started on meropenem and metronidazole and IV fluids.
Okay.
He was not responding to IV fluids, started on inotropic supports.
What is the rationale of giving meropenem with metronidazole?
Meropenem, because of procal being so high and being immunocompromised state.
Okay.
So meropenem higher antibiotic was started. And acute gastroenteritis to cover gut anaerobes specifically, metronidazole was started.
Gut anaerobes will not be covered by
Will be
meropenem?
covered. Meropenem will be covered.
cover.
Yes, sir.
What is the reason? There may be some reason why the doctor is adding metronidazole to that. It is not to cover the anaerobe. Anaerobe will be covered by, if you have a good knowledge about antibiotic, meropenem will easily cover. Metronidazole, tinidazole, secnidazole, all started for what?
Concentration is the antibiotic.
No, for which organism? In a patient who is having diarrhea, doctors start
Amoeba.
They are thinking in terms of amoebic dysentery and starting this metronidazole, tinidazole, secnidazole, all these things.
Yes.
Not for covering the anaerobes. Okay.
Yes. With a diagnosis of sepsis with septic shock, urinary tract infection, lower respiratory tract infection, AKA with metabolic acidosis, and during the hospital stay he developed AF reverted and ACS and STEMI with decreased LV function.
How do you manage AF case in your emergency medicine or in ICU? This patient has developed AF.
AF with fast ventricular response.
Okay. So how do you manage it?
We can first we have to look at his LA is dilated more than 4 centimeters or not. If it is more than 4 centimeters, rhythm control is not indicated. We can directly target rate control. And with rhythm, if LA is not dilated, that means it's not a chronic AF. Taking it as a paroxysmal AF, we can start rhythm control. If it is a structural valvular disease is already there, amiodarone is a drug of choice. If not a known case and valvular disease is not there, we can target.
How do you manage? According to ACLS, you have a AF with fast ventricular rate. How do you approach the patient?
Stable, unstable.
That is the first thing.
Yes,
Whether the LA is dilated or LA is normal, patient has to be stable.
Stable.
If the patient is unstable, your treatment,
DC
entire treatment is different.
DC cardioversion.
Okay, that you have to go to that side. If the patient is stable, then you have to manage two important things. One, you have to control the rate. Then you have to prevent the embolism. Rate control also, if you are very confident, you can do it. There is no issue. How do you control the rate?
Rate we can give beta blockers, metoprolol we can give.
What is the dose of metoprolol?
Metoprolol we can start with 5 mg.
Okay, how many doses you can give?
Usually we can give at one dose and wait for 5 to 10 minutes. If it is not controlled, we can repeat a dose.
Okay, one more. You can give up to 15 milligrams without any problem. Okay, metoprolol can be given. What are the other drugs can be given?
Other drugs we can give, other beta blockers can be also given. And
one more beta blocker.
Calcium channel blockers we can
you
give.
have to tell properly.
Yes.
Diltiazem or?
Verapamil
what is the
we
dose
can
of
give.
diltiazem?
5 mg.
5 mg.
0.2.
Okay.
Yes.
Verapamil.
Fine.
All these things are given in ACLS protocol. You have to read that.
Yes, sir.
Okay. Third doubt, you have to give it all these things because we cannot refer all these things immediately. You have to give.
Yes.
Okay. So either beta blocker or rate
Verapamil.
limiting calcium channel blocker.
Yes, sir.
Okay. So that can be given. Suppose you want to control the rate and rhythm together and BP is slightly lower, not completely low like you talk about hypotension or other problem, but slightly lower. You are not confident enough to give beta blocker. What else you can start? Patient's BP is only 100/60 like this patient. AF is there. You don't want to give shock. You don't want to give beta blocker. Amiodarone. Amiodarone is the best choice. Okay. So amiodarone will not produce much hypotension. You can easily control the rate and rhythm with amiodarone. But that is not the first line choice according to ACLS. That's all. Okay. If the patient is having unstable, then you go for cardioversion. How do you cardioversion?
For AF, we can start with 100 joules, follow like increasing like 200 joules.
What do you say? How do you give shock?
Give shock.
Tell me how to give shock.
First of all, you take
We have to take the
Consent will be taken.
then sedate the patient.
Sedate the
patient and
Thromboprophylaxis heparin should be given.
heparin should be given.
place the monitor leads.
Place the leads properly.
Cardioversion.
Cardioversion mode എന്ന് പറഞ്ഞിട്ടൊരു
Synchronize.
You have to tell it properly. You have to press synchronized mode. Then only you have to give shock. Okay. After giving shock, then can you take out the leads immediately back?
No,
Sorry.
more 10 seconds.
You have to wait. Okay. So you have to wait some more time. So these things you have to be very carefully executed. Okay.
Yes, sir. And patient was declared.
DC cardioversion പറഞ്ഞൊരു മോഡ് ഇല്ല വെന്റിലേറ്റർ
Synchronize.
Synchronize button you have to press. That's all. Don't tell like that because someone else may go and search DC cardioversion mode in the defibrillator. Is it a mode in that?
No, sir. Synchronize.
Okay.
Yes, he was declared.
Okay. So this patient had sepsis.
Sepsis with septic shock. Urinary tract infection. Lower respiratory tract infection.
Okay. Normally in a patient with sepsis-induced renal failure, how do you know that it is AKI or CRF?
Sepsis-induced AKI.
No, you are telling it is sepsis-induced AKI. Past history of kidney disease was not there. How do you know that this patient is having AKI or already pre-existing chronic renal failure?
We can, by laboratory wise, we can look for proteinuria and we can send
proteinuria here it is not possible.
Yes.
It is not a good investigation in emergency medicine at all. It is all useful in a chronic OP practice.
Urine ACR can be estimated.
Urine ACR also, all these things you can do in your OPD. But here it is not a good investigation.
USG we can do.
USG is the easiest one. What do you look in the USG?
For corticomedullary differentiation.
So that is the most important thing you have to look for.
Yes.
Then anemia. Anemia can, here it may be because of the hemolysis itself, but if the patient is having renal failure with anemia, then it is probably chronic renal failure.
This patient also had like stool occult blood positive and he went into DIC also separate.
Okay. What is DIC?
Disseminated intravascular.
How do you diagnose it?
Hypofibrinogen will be there.
What are the three components of DIC?
D-dimer and consumption.
D-dimer is not a component at all. Because D-dimer is only a add-on investigation. You get D-dimer positivity in many diseases.
Yes.
What are three components? One is internal, what is that? Internal pathway. Internal pathway, external pathway, common pathway.
Intrinsic,
extrinsic and common. So these three pathways should be affected. Then only you can tell the patient is having DIC. So anyway, D-dimer will be elevated in DIC. So what are the three things you have to look?
Conceptive thrombocytopenia will be there.
Thrombocytopenia may or may not be there. It can be there.
PTI elevation, APTT will be elevated. APTT will be elevated.
Is elevated.
Hypofibrinogenemia.
What is the range of fibrinogen?
Less than
Less than
100.
150 is normal. Less than 100 is diagnostic. Okay, so that is very important. So you have to, when you make a diagnosis, these three things should be there, and sometimes associated thrombocytopenia also can be there. Okay.
Yes, sir.
How do you manage anemia in chronic renal failure?
Erythropoietin we can start
How
off on the
much?
patients. 4,000 international units are based upon like once a weekly or twice a week.
So what is the target?
Target more than 10.
More than
10.
10. Okay. Anything else you want to add?
No, sir.
Okay. Okay. Thank you.